As I say, I don't think one should make a big deal of it, but I think it is worth keeping in mind that what one records as the compound nerve action potential may not ever or often be strictly correspond to the afferent fibers resulting in the cerebral potentials. Parenthetically, I should mention that electrical thresholds of the small myelinated fibers of nerve, the A delta fibers subserving pain and temperature, are at least an order of magnitude greater than for the larger fibers. And C fibers, unmyelinated, are still an order of magnitude higher. Therefore, it seems clear to me that under normal circumstances of clinical study, these fibers are playing no role and are not in fact being excited. There are some reports of relatively long latency cerebral potentials evoked by natural pain and temperature stimuli. It's a little bit difficult to evaluate these. In fact, they don't seem to have any clinical significance. I'd be a little happier if someone did the same kind of observations, that they, for example, disappeared with lesions involving the crossed anterolateral pathways in the cord. Now back to electrical cording for a moment. The most proximal site at which the action potential of the upper extremities can be recorded is indeed at Erb's point. Again, this is volume recording, near field, recording in the fibers in the brachial plexus and the as they go through the supraclavicular fossa. And this, as you've heard, yields a sizable potential with a latency of about 9 milliseconds from stimulation at the wrist. Now, the earliest potentials that we recorded with electrodes over the contralateral scalp, over the contralateral sensory motor cortex, with a scalp or ear reference, i.e. a cephalic reference. The earliest is N20, believed to indicate arrival of impulses in thalamocortical fibers at the cortex, followed by P22, P28, N30, etc., etc. So, the cortical potentials that I'm referred to are indeed synaptic potentials of cortical neurons. They are recordable from the cortical surface and from the scalp because these pyramidal neurons extend through the cortex have a strictly vertical orientation, so that EPSPs and IPSPs at their depth, at the soma, or superficially over the apical dendrites, give rise to recordable, surface recordable dipoles. By contrast, as Dr. Kimura indicated, synaptic potentials in the cuneate and thalamus do not give rise to volume recorded potentials at any distance from them, simply because they are small cells with relatively random arrangement, and this is the so-called closed field situation. So that the nerve action potential and the cortical potentials, synaptic potentials, are the open field situation. So that until relatively recently, we were left with a gap in time, 10 or 11 milliseconds, between the arrival of impulses, the brachial plexus, recorded at Erb's point, and at 9 milliseconds, and the arrival of impulses at the cortex at 20 milliseconds. As you heard from Dr. Kimura's very elegant presentation, we filled this gap in. Anatomically, the gap corresponds to, beyond the brachial plexus then, fibers in the dorsal roots, in the cuneate, in the dorsal column, in the medial lemniscus after the synapse, and finally in the thalamus. This is an early example of what Dr. Kimura was talking about. I believe this is Krakow's work. These are the potentials. These potentials that don't show up on the scalp with scalp reference or ear reference because they're isopotential over the head, but show up with a remote non-cephalic reference. In this case, hand is the contralateral hand, and these are the far-field potentials that were discussed. And fortunately, I don't have to say too much more about them. They appear as negative potentials, as I understand it, with the same latency when they're recorded by electrodes over the posterior neck. Now, I simply will reiterate what Dr. Kimura said. These are volume recorded. They seem to arise when there's a change in the geometry of the volume through which the pathway is passing. That's about as far as my limited knowledge of electricity will take me. And examples of where the volume is expanding is where the fibers are entering the spinal canal, and again when they're entering the skull at the foramen magnum. I need to say very little more about this. There has indeed, if you make the mistake of reading all this literature, going back to the early days, there is an extraordinary amount of controversy about the exact origin of these potentials. And reading the literature somewhat reminds me of the writings of the medieval scholastic philosophers. I just would remind you that where in many cases these disagreements are referring to things which are only millimeters away. Nonetheless, you will find it confusing. And just to summarize once again, what I believe are the most accepted views: synaptic potentials don't play a role. The earliest far-field potential is roughly P non, which is said by some to slightly precede the Erb point potential, which is P non, so that its impulses in brachial plexus a little before that point. P11 is said to reflect afferent volley traversing the dorsal rootlets. P13 and 14, dorsal column at the foramen magnum, according to some, or medial lemniscus, according to others. There is a component, according to Desmet, of the P13, not all of it, but a component of it, which may have a somewhat different origin. It's recorded as negative over the neck, positive with an electrode ventral to the cord, and may represent synaptic potentials in dorsal horn, and a somewhat similar potential is claimed to be recordable from the lumbosacral cord. P15 is more rostral, either medial lemniscus or thalamus, and there is also said to be a N18 which has a wide field and is therefore a subcortical origin, as opposed to the very restricted field of N20. And many of us have apparently been guilty of confusing these two potentials, at least according to some. Okay. So now let me go on and talk about some of the clinical applications of SEP recording, beginning with the evaluation of the peripheral and central afferent pathways. And as I say, I could stop at this point because almost everything I'm going to say will be the subject of more detailed discussions by others later in this conference. But I'm not going to stop. I'm going to go on anyway and get in my 2 bits. I am also going to probably be somewhat more iconoclastic about the usefulness. So you can keep this in mind when you're listening to later authors and see whether, in fact, you feel that they're making their point. First of all, peripheral nerve. I was rather surprised, personally, and I'm still somewhat puzzled, that somatic sensation could be virtually normal in patients with peripheral neuropathy or recovering from peripheral neuropathy when the peripheral nerve action potential is not recordable at all, presumably due to desynchronization of impulses. Now, granted that some or even most of the axons are still conducting, they're just desynchronized in their conduction times, I still am surprised that a very precise type of sensory information with tactile discrimination, two-point graphesthesia, and proprioception can be preserved in the absence of a recordable nerve action potential. The same, it turns out, is true, as you will see a little bit later, for slowing of conduction in central pathways like the cord and the meniscus. Now, even when the desynchronization of impulses in peripheral nerve obviates recording a compound action potential, nonetheless cerebral potentials may be recordable, albeit delayed in onset, latency, and degraded to low amplitude, slurred potentials, which are not readily identified with normal components of the SCP. The upper traces, A and B, are from a man who had recovered from a neuropathy, and at this point had virtually normal sensation, a little dysesthetic, that's all, no significant sensory deficit, no action potentials recordable from peripheral nerves, even close to the site of stimulation, but these very abnormal cerebral potentials, the onset peaks are one is from stimulation of the finger, the other the wrist, and the delay between the onset latencies in those cases was 7 milliseconds as opposed to the normal 2 or 3. Now, some people looking at this have talked about amplification at central relays, and this is to some extent feasible because there is indeed convergence and divergence in the Sherringtonian sense at the cuneate, not a great deal of it, at the cuneate and the thalamus. What I think is most improbable is what has been called a resynchronization. Resynchronization would depend on a temporal summation of synaptic potentials, and indeed the EPSPs at dorsal column nuclei, at any rate, are extremely brief, and the temporal summation is just not feasible. Of course, the other explanation is redundancy. You don't need all those fibers conducting, but I still repeat, I would still repeat that I'm surprised how normal sensation can be in the face of absent peripheral action potentials and grossly abnormal cerebral. Some have advocated stimulating at different sites in the limb in patients with non-recordable evoked potentials, with neuropathy and non-recordable action potentials, to get a very crude estimate of conduction velocity in the limb using the latency of the central potential. Frankly, it scarcely seems worth the time or effort to me. SCPs have also been utilized and suggested as being utilized to evaluate conduction of the more proximal segments of the peripheral pathway, plexus and nerve root, where standard electrodiagnostic methods are not readily applicable. Guillain-Barré is sometimes mentioned, granted that early in the course of Guillain-Barré demyelinization may affect only the roots, but after all it's the motor roots we are interested in this case, and they may be assessed by means of H and F wave recording. I see no use for SCPs. With injuries of the brachial plexus, a component of the injury can be avulsion of dorsal roots from the spinal cord. This would result, of course, in sensory loss and loss of central SEPs, but the peripheral nerve action potentials would be preserved because their axons retain their connection to the cell body in the dorsal root ganglion. This, of course, is something which cannot be surgically repaired. In practice, it seems that the traction injuries of the brachial plexus are not so simple, And one has indeed a combination of damage to preganglionic fibers in the plexus as well as dorsal root avulsion. And as I say, the results are unclear, although others may argue differently or even ambiguous. Parenthetically, clinically, the surest indication of dorsal root avulsion is the pain, which almost invariably results. This is a continuous burning pain on which are superimposed paroxysmal exacerbations of excruciating severity. This is a type of deafferentation pain which is resistant to most methods of management except dorsal root entry zone lesions. It was also hoped that SEP recording might illuminate the somewhat murky entity called the thoracic outlet syndrome. This is being claimed by one group, but doesn't seem to be the experience of most. The rare neural form, I've only seen a couple of cases, which consists of progressive weakness and atrophy of thenar and ulnar hand muscles with some ulnar sensory disturbance, ulnar disturbance in the limb, is so characteristic as to scarcely need any further electrodiagnostic evaluation. Just go ahead and do it. The more common non-neurological form of the syndrome, in which there are no hard findings on clinical evaluation, has, I think, also eluded electrodiagnostic studies. Now, a more common problem, of course, by far, is pain in the upper or lower extremities caused by root compression due to herniated disc or foraminal disease. And here, in my experience at least, speaking as a clinician, history and clinical exam supplemented in some cases by some routine electrodiagnostic studies, and most importantly by modern neuroimaging, CT scan with contrast and MRI, usually gives one quite enough information. Myelography is no longer generally required, although some neurosurgeons like to see it. Now, it is true, however, that techniques which you'll hear about have been elaborated which permit which permit evaluation of individual roots. No use stimulating the nerve trunk. The median nerve tactile fibers go in over both 6 and 7, proprioceptives over 8 and T1. However, by stimulating, for example, the thumb, the middle finger, and the fifth finger, you are in fact evaluating conduction over C6, C7, and C8 roots, respectively. And similar kinds of segmental stimulation are available for the lower extremity. Now, such evaluation, it seems to me, I've never done it, is quite time-consuming, and I think it should be left to those who have a special interest and expertise in this area. In other words, what I'm saying is I don't think it is feasible that it should be a routinely offered study by every lab. However, you may well hear others disagree with this. Now, SEPs can also be used to evaluate the central pathway with lesions affecting specifically dorsal and dorsolateral columns of the spinal cord and the medial lemniscus, and which are associated clinically with tactile discrimination and proprioception. SEPs are often absent, or as with peripheral lesions, delayed in onset, degraded to poorly defined and simplified configurations. By contrast, when lesions are confined to the anterolateral spinal cord or the lateral brainstem, SEPs are perfectly unaffected. This is an old slide of mine showing afferent impulses at the elbow associated with cerebral potentials to shocks applied to the median nerve at the wrist, motor threshold above, well above motor threshold below. This is from a man aged 27 with progressive cerebellar ataxia and proprioceptive loss with intact pain and temperature. The next slide is a patient of Desmet's, patient with MS with a normal subject for comparison. Again, action potentials at wrist and axilla from stimulation The digits were normal, but the cerebral potentials, as shown in C, were delayed by 23 milliseconds compared with the normal D, and notice the different amplitude, the totally different amplitude calibrations. So, as with peripheral nerve problems, SEPs may be markedly abnormal in patients with lesions affecting the central afferent pathways. And once again, this may be true in the absence of any disturbance of somatic sensation as detected by clinical exam. And of course, this has given rise to the almost universally agreed that one of the most rewarding applications of SEP recording is in the identification of clinically silent and otherwise unsuspected lesions in the diagnosis of demyelinating disease. As you know, the clinical diagnosis of MS depends on the identification of multiple lesions, at least two in the central nervous system, which are not connected, as it were, dissemination in time and space. Thus, while a single or multimodal evoked potential recording in a patient with definite MS with lots of findings is a total waste of time, and similarly, SEP recording from a limb with typical sensory deficit is likewise. The identification of abnormal evoked potentials from a limb without sensory deficit is extremely useful in providing one with a new second or more lesion. I would include in this case recording from an affected limb where the sensory symptoms are very bizarre. And indeed, this is often the case in demyelinating disease. As a matter of fact, the more bizarre the sensory symptoms, the more likely the diagnosis is to be MS. I feel as if my foot were encased in concrete. I feel as if cold water were trickling down my leg, or someone had tied a tight ligature around my big toe. A clearly abnormal SEP evoked from such a limb would seem at least reassuring in heading towards the diagnosis. Incidentally, there's a poor correlation between SEP and MRI, and so these are supplementary or complementary procedures. They're not, one doesn't necessarily, although one is a lot more expensive than the other, one doesn't really interfere with the other. Unfortunately, early in the course of MS, the results may be rather disappointing. While abnormal SEPs are found in 80% or more of patients with definite MS, and I'm sure it's more, they are only abnormal in about 50% of those classified as possible, who are the ones you're interested in. This is somewhat higher, by the way, than for visual or brainstem auditory. Specifically, Matthews found abnormal SEPs in only 4 of 49 patients who presented with optic neuritis. If 1/3, or roughly 15%, of patients who present in such a way are expected to develop MS in long-term follow-up, that's a rather small proportion. All right, well, let me go on now to consider SEPs in patients with cerebral lesions of the cerebral hemispheres. First of all, diffuse disorders, such as anoxic encephalopathy. Dr. Kasvan will be talking about that. Or trauma severe with coma. Very briefly, absence of evoked potentials is clearly bad news. An absence of subcortical potentials even worse. This correlates very well with the absence of brainstem reflexes, which of course are much more easily and quickly elicited by any clinician. So what are we gaining? Recovery is another matter, and a relatively normal SEP by no means guarantees it. Certainly the subcortical potentials are presumably preserved in patients who have whose brain stems have survived and whose forebrains are gone forever, but these patients commonly end up in a chronic vegetative state. Now, again, others may disagree with this evaluation. Just parenthetically, among the diffuse abnormalities of brain, I should mention the anomalous situation of Wilson's disease. In this condition, it has been shown that all types of evoked potentials are really quite remarkably abnormal. But this, I think, has to be regarded as something of a curiosity and absolutely to lack any practical significance. True, deposits of copper in the brain in this condition are ubiquitous, but the clinical abnormalities are, apart from psychiatric abnormalities, strictly confined to the motor system, primarily extrapyramidal and cerebellar. To mangle a quote, I know Wilson's disease, and this thanks to my long association with Drs. I.H. Schonberg and Sternlieb at Einstein. I've seen 40 or more cases with neurological abnormality, and we make the point that any disturbance of sensation, visual, somatosensory, or what have you, is never seen in this disease. If it is seen, it's due to something other than the disease. The diagnosis is made by thinking of it and by looking for the Kaiser-Fleischer rings, which are invariably present by the time any abnormality of neurological function has appeared. It might be of interest in those patients, however, if someone wants to do it, to see if there's any return of evoked potential towards normal as a result of treatment. Could be. As for focal cerebral lesions, vascular, neoplastic, traumatic, you name it, there is indeed a good correlation between loss or absence, abnormality of SEP, clinical sensory deficit, tactile discrimination, localization, proprioception, and whether or not the lesion involves sensory motor cortex or not. That's what you'd expect. That's what you get. And this is an old slide of mine, the normal afferent inputs, the patient who had a moderate, in this case, moderate degree of cortical sensory loss affecting the left hemisphere following carotid occlusion. Very little, if anything, there, normal on the right. Of greater interest, obviously, are situations in which there is some kind of discrepancy between the evoked potential findings and the clinical situation. There is such a situation, for example, in patients who were diagnosed clinically as having pure motor stroke. Some considerable percentage of them, almost 50%, were said to have attenuated SEPs on the affected side. Now, pure motor stroke is generally due to a lacunar stroke affecting the internal capsule, which of course is right adjacent to VPL, and even clinically, pure motor stroke is often not pure motor stroke but has some sensory deficit. Now, conversely, I reported, and others have mentioned such cases, I reported patients with cerebral lesions in whom cortical somatosensory evoked potentials were normal or relatively so, and these from the damaged hemisphere. And these patients showed a sensory deficit, which was typical cortical sensory deficit, and in some cases quite severe. This is from my best studied case. This was a patient, I mentioned this situation several times before, evoked potentials left and right hemisphere before biopsy in the upper records when the sensory deficit was mild, both after biopsy when this patient developed a very severe sensory deficit and with characterized clinical sensory deficit, yes, characterized by, first of all, a dramatic increase in the sensory threshold to electrical stimulation, such that the record, such as the In the C, A, was the evoked potential recorded when the stimulus was subthreshold, and B was when it was suprathreshold, and there isn't a hell of a lot of difference. So and the other feature, the other clinical feature of this patient, this wasn't the only one, the other clinical feature was that these patients showed extinction on double simultaneous stimulation, and the lowest record is obtained during double simultaneous stimulation. It's the same intensity as CB. CB was above sensory threshold. The shocks evoking the D were not reported by the patient, but they obviously produce a nice evoked potential. So the common features are, in this group of patients, a perfectly typical cortical sensory deficit, quote unquote, marked increased threshold, sensory threshold to electrical shock, and extinction. Now, I think it is reasonable to include the following, and I have concluded that in the past and will again, and would be interested in any comments. First of all, we know, I think, that SEPs are generated exclusively, the ones that we record as intermediate latency are generated exclusively in the sensory motor cortex. And that this sensory motor cortex in these patients was spared by the lesion. In fact, this was before the days of CT scanning, but the lesions were in the parietal cortex posterior to the postcentral gyrus. The second thing, or the third thing one could conclude, is that cortical sensory deficits can indeed result from parietal lesions, which primarily, which do spare the postcentral gyrus, and perhaps are primarily due to elevation of sensory threshold. That is to say, the parietal area involved in these lesions must play some role in maintaining sensory threshold at a low and stable level in intact subjects in some tonic fashion, and make a lesion in this area even though the impulses are reaching the postcentral gyrus, evoking normal potentials, the patient no longer experiences, no longer can report the sensory experience. Furthermore, it's my contention that in such cases, the prognosis may be appreciably better for recovery of sensory function, and indeed, this patient was studied serially and did slowly improve clinically. Now, others have noticed preservation of SEPs in patients with stroke, with cortical lesions in general, but have not commented on threshold abnormalities or relation to extinction or very much about prognosis. I find the recent observations of Maguire, Desmet et al. To be of both scientific and clinical interest. Very briefly, they contend that the P22N30 are generated in the pre-Rolandic cortex, while N20, P27, P45 are generated in post-Rolandic cortex. That's why I specifically referred to the projection to the pre and post cortex straddling the Rolandic fissure. And that indeed it is possible to have lesions, which they found, which result in either a motor deficit without a sensory and a sensory deficit without a motor, and the appropriate loss of either the P22N30 when there's a motor deficit and the N20, P27, P45 when there's a sensory deficit without a motor deficit. I plan to make a slide of their data, but frankly, they present it in such a way that it is really not readily apparent. You have to work to see what they're talking about, but it is there, and I do accept their findings. This question of generation of potentials in the precentral gyrus, first of all, by afferent input, first of all, has a respectable basic animal physiology history, and it was also addressed in the past by various people, specifically, for example, by Goldring in 1970, who used the criteria of reversal of potential in penetrating the cortex when you get to the underlying white matter. If that didn't occur, then his argument was that it was volume conduction. And he found this in 12 out of 18 patients, that they did have potentials which he judged to be generated in precentral gyrus. So what about the other 6? And he rather lamely said, well, maybe people are different. I find that very unsatisfactory. However, if this is indeed the case, then indeed there are different cortical generators for the different potentials, the ones that I've specifically mentioned. And I suspected this way back when, because if you notice, the P22 and the P30 in this case are of maximal amplitudes at different scalp locations. The standard is what would now be called C-3 or 4. It was Dawson's and mine 7 centimeters in the midline behind the Rolandic fissure. And these are recording from anterior and posterior sites. And at AM, only the P22 is seen, and at PL, posterolaterally, the P30 predominates. So I didn't make a big deal of it, but this would certainly somewhat support what has been claimed. I have some difficulties with it from the basic science point of view. I have no question that there is a tactile input to the motor cortex, at least well demonstrated in primate. It is tactile. It might have been nice if it was proprioceptive. The proprioceptive input appears to terminate in the depth of the Rolandic fissure rather than the motor cortex. But so be it. I do think that this is an interesting observation. Well, finally, just for 1 second, let me mention a situation in which SEPs in general are enormously enhanced. And this occurs, of course, in patients with various types of progressive myoclonic epilepsy. And this finding is as near to being pathognomonic, as a pathognomonic abnormality of the SEP as there is. I should mention one just in passing, but it may be mentioned later on. By and large, one does not detect changes in the amplitude of individual components of the evoked response, but Hallett and others have made the observation that the N30 is diminished, relatively diminished in patients with Parkinsonism and enhanced in patients with dystonia. That's the only example I know of of taking one component and upping it or downing it. Anyway, in terms of the huge evoked potential business again, this is an example of the SEP in a 4-year-old child suffering from late infantile onset ceroid lipofuscinosis. And if you look at the gain, you can see that this is an enormously enhanced, even the P wave, the first P positive wave is some 50 microvolts, which is 5 times normal, and the succeeding negative wave at 38 to 45 is even bigger, but the overall configuration is relatively normal. This is not the only condition in which that occurs. I had other patients that I studied who, in adult life, who had very similar type of enhanced evoked potential associated with myoclonus. A very unusual situation is shown in the next slide. This is from a patient who suffers from an excessively rare condition known as the cherry red spot myoclonus syndrome. She was 28, very slightly impaired intellectually, had a 5-time greater than normal initial early positive potential, and even larger positive potentials, 65 to 72 and 102 to 120, which are seen after that, which don't correspond to any component of the SEP in normals. Well, rare as these patients are, I think that the observations have some important implications for understanding cerebral mechanisms. And very specifically, the fact that these enormously enhanced evoked potentials are seen would imply to me that there is in these patients, some abrogation of normal inhibitory mechanisms in the cortex. And furthermore, there is the implication that in healthy subjects, inhibitory mechanisms, very powerful, tonically active inhibitory mechanisms, are limiting the response to thalamocortical input. Furthermore, they reveal what is an otherwise unsuspected cerebral mechanism, namely a short latency afferent evoked output from the cortex, presumably motor cortex, relayed via corticospinal pathways. An example, if you will, of a long loop reflex, which is manifest in these patients as their evoked myoclonic response, but is presumably latent in us all. The shock in these patients evokes not only the huge potential, but the myoclonic response. These are individual records from a patient, such a patient. The first potential after the stimulus is the direct motor response. The later one is the evoked. This is the direct motor response. These are stimuli of the same intensity, and this is the thenar muscle evoked myoclonic jerk. These are the corresponding SEPs, and as you see, if you want to, there is a rough correlation in the amplitude of the cerebral response and the myoclonic jerk responding. This is simply the same thing at a longer time scale. This is real, and it certainly is worth further study of this type of patient, rare as they are. Well, I conclude at this point. I think you may get the feeling that I'm a little bit tough on the evoked potential field. I think that there are relatively few places where, for the clinician, it offers information not otherwise available in diagnosis of management, MS, of course, being one of them, and these other rare situations, and possibly the situation of parietal lesions. And from the scientific point of view, well, certain things that I alluded to, I think, are of interest, and I certainly would hope that by going on with this kind of work, more will appear. Thank you very much.
This may not be so much of a question as an observation. The patient that you showed where the SCP was basically present, all right, but who had sensory loss, we see a similar phenomenon during anesthesia. In your patient, the initial potential was present, but the later ones were quite schlepped out, to use a scientific term. Yeah, the early stuff. What we see, in fact, I have this in the handout that I gave, is that if you compare patients who are awake to those that are anesthetized, during the state of anesthesia, those early potentials are present, and it's the later ones that are basically either absent or very prolonged as well. So there might be some relationship between those later potentials and their clinical sensation versus the early potential.
I absolutely agree in man and animals, you would expect the early potentials to survive anesthesia because the synaptic relays are so potent and resistant to anesthesia.
Yeah. In fact, we used to think, and I'll show some slides on this, that we could almost tell when the patients were getting light as those later potentials start to move back, etc. The other is for the sadistic John Kimura, because John, you said something about...
I have a question to you.
I got you first.
Okay. No, my question relates to
okay.
what we have just been discussing. I think we see the opposite also. Isn't that right? When you have the, in other words, you may lose the early potentials, or in fact you may lose the sensory potentials peripherally completely, and yet the late component of the somatosensory potential is completely, is very well preserved.
Well, I would suggest that you can't, as I was showing in those slides, you can no longer, when you have a loss of the afferent volley recordable due to desynchronization. What you get from the recording from the hemisphere is so degraded, so delayed, there's no way I think you can identify what that is. Is it an early potential which is slurred out and delayed, or is it a later potential, or what have you? So I submit that it's not possible to identify those potentials.
Okay, what do you say?
No, John, you had mentioned when you were trying to do some of these far field potentials from the lower extremity, that one of the problems in looking at, was it P17, P24, etc., it was difficult to do originally. You didn't get it all the time, but now you have the technique, and then you went on and you never said anything about why does this new technique?
No, we do not. It is still difficult.
Oh, I thought you had said that now
I don't want to mislead that. Had we have technique that we can record them consistently every day without spending much time, if you spend a lot of time, you can always record them.
Oh, okay.
Because you have to be very careful about the resistance and everything else, and the impedance and the interference and so on.
I thought you were saying that you now had a technique that you could do it routinely.
No.
Oh, I'm sorry. That I misunderstood then. I take back
that
the
being
sadistic.
The case, if you can't see them, what do you make of it? I mean, maybe it's technical.
Right, and that's why that kind of difficulty precludes the use of far field potential this time. Right. But for theoretical purpose, it's all right because we know, we can spend a lot of time for that.
With the array, say cephalic to limb or something, is the EKG a problem?
Yes, it could be, although we trigger with EKG, and so that we are going around circumventing that problem.
Yeah,
right.
That's at least one of the tricks is to try and get a flat part of the EKG, or certainly a trigger related to it. And the other one, of course, is to try and get a shielded room so that you don't have as much 60 hertz, so that you don't have to use as much common mode rejection as a problem. I should point out that common mode rejection implies that the signal is the same, but by the time you have an antenna that is several feet long, or 6 feet long, I mean, you're approaching the, what Hertz used to get radios. So therefore, you should not imagine that the interference from the room when you're coming even though you're a few feet away from the the interference from the fluorescent lights may very well have a potential difference between the head and the toes, etc. And so their attention to the details and so forth is very critical in trying to record under these circumstances. The near field recordings, where you put things that are very close, are not as great. And the more that you separate them for the far field effect, the greater that these problems can occur. The other thing to understand is that impedance is important, but for common mode rejection, it's the balance of the impedances that are the most important. That is to say, it's a very nonlinear function as to how much your common mode rejection deteriorates as your ratio of the impedances on the two electrodes differ. So that if you can get the impedances on the two electrodes the same is the time when you have an optimum common mode rejection. And so if you are having technical difficulties, then I pay attention to that as well.
Well, another major problem is that when you stimulate, and if your stimulating electrode is in between G1 and G2, it is just about impossible. And I wonder if somebody knows how to get around it. Sometimes you would want to do that, you know. In nerve conduction studies, of course, you say that you always press the ground between stimulating and the recording electrodes. But in far field recording, sometimes you want to stimulate with G1 way separated, and you're stimulating electrode in between, and it just makes it very difficult.
But I thought that was precisely what you were doing. You were putting your reference electrode distal to the site of stimulation on the limb. So that is, you were saying that's the problem.
Another limb usually. See, that's why.
Another limb.
Yeah, that's why you stimulate the tibial nerve, and then press one electrode here and the other electrode on the knee, but on the other side, just to escape that particular problem. Yes.
Okay, totally version. I'm trying, as an old man, I'm trying to analyze why Dr. Giblin, who was one of the pioneers of the somatosensory evoked potential research, why should he be tough on evoked potentials?
Well,
and,
maybe because I'm an outsider now,
yeah,
you see. And remember,
may I
look at it from the point of view of a practicing clinical neurologist.
Yes, may I continue?
What's in it for me?
May I continue? Okay. My conclusion is that most of these two gentlemen, or most of these two gentlemen, are polarized on the original segment of evoked potential. Now, from the historical point of view, I like to say that I lived in a happy period when the terms of near or far field potential were not in vogue, and when I, with Kim, analyzed the surface of the skull, and we found that going backward, we got to a point to the neck at which we found negative potentials with a extraordinary latency of only 13 milliseconds or 14 milliseconds. And of course, contrary to the experience of Dr. Jewett, I didn't say it is the artifact. Other people said that what I recorded was the artifact. Exactly. And in order to prove that it wasn't artifact, my technique was to find a neurosurgeon who, during the surgery on mesencephalon, permitted me to record the potentials, and then I found that these potentials are really mesencephalic potentials. And I believe that the neurologist and neurophysiologist 30 years later spent too much time on the finesse of this recording. I feel that the fact that we have a possibility of recording conduction velocity in the brain stem is enough of a contribution of somatosensory potentials in this particular range, and also that one should be more careful in differentiation between 13 and 14 or 14 and 15, because when we stimulate the median nerve at the wrist, in certain individuals we have 2.5 milliseconds, in other individuals we have 3.5 milliseconds, and it is both of them are normal. So I think it is presumptuous for us on a higher level of 15 milliseconds, of 13 milliseconds, to make such a fundamental difference for the diagnosis. And based all the theory on this, I'm sorry.
When one goes to the late components, then we really have a major contribution. And what you said about selective stimulation of the nerve, one has to be clear about it. In order to suppress a contraction by stimulating the median nerve, you have to use 100 millisecond progressive onset. In other words, way beyond the duration of the evoked potential. So this technique, unfortunately, is not good. However, what I did, I stimulated with, like you said,
20 microseconds, and 300 microseconds, or 200 or 100 microseconds, and then the evoked potential are completely different. Then you feel a complete difference when you stimulate with the currents which can involve the pain fibers. And if anybody wants to comment.
I'd like to ask a question.
No,
I'm sorry.
Sorry. First of all, I'd like to defend the critics. Good enemies are hard to find, and so those that say, okay, you're very enthusiastic, but let's get down to the bottom line, where's the beef? Show us how it's really important. Those critics are useful, and I think they should be cherished as well, so they have to be answered, I think, appropriately. Returning to the technical issues, of course, clearly this is why it's a research area and not a clinically applicable area, but another way to reduce the stimulus artifact is a so-called balanced pair, where you can add a potentiometer and try and balance between them. Essentially, putting a stimulus pair in one direction, add another stimulus pair in the other direction. Hopefully what you're doing is ultimately either stimulating inactive tissue or some other variant of that. So it's certainly conceivable that you can do this, but it takes careful planning and so on to reduce the stimulus artifact. And ultimately, if you've got enough latency, you can if you can reduce the artifact so that it's gone by the time that your potentials are there, that's another other option. Also, amplifiers that will block during the time of the stimulus artifact so they don't overload, etc. But it's a technical problem that is best left for those that are willing to be masochistic to continue to try it.
Okay, anybody has a question? I want also to ask. Niels Pierholz again?
Well, no, just the point is that if that technique could be made clinically feasible easily, it would be very helpful in the operating room, whereby one of our issues is the impulse getting up, let's say, to the spinal cord okay, et cetera. So if there would be a relatively easy way with just 2 electrodes of getting the near field and the far field, I say, to me, from the practical use in the operating room, that would be terrific, instead of having to go to multi-channel recording. That's why I was particularly interested in it. But we don't have the ability in the OR just to simply work in a well-shielded room, because, the OR environment, I have to tell you.
And Dr. Pavot, I would like you to discuss the timing and the clinical utility of evoked potentials in prognosis and brain injury. The couple of papers I've read in the literature in terms of somatosensory prognosticating recovery were done within the first 72 hours when the patient was still on neurosurgery. What about for the physiatrist that's asked to consult and then reconsult on patients that are making very slow recovery? When is the proper time to get these, and where does clinical judgment come in, and the utility of multimodal and then somatosensory also?
It's an interesting question that you've made, because several studies and papers have appeared on studies done on brain-injured patients at various intervals of time. Ideally, certainly if one does them within the first week, or when they're still in the intensive care unit and you're able to come up with some useful information, this is where, up to a point, you maximize the value of this particular methodology, in the sense that you're able to get a pretty good feel of how the patient is going to do. But even in a number of instances, doing it, let's say, a month post-injury, it has been shown again that in a number of these patients, one was able to predict more accurately using evoked potential studies than a careful neurological examination. So I don't know if I fully answered your question, but even examining a patient as late as 3 or 4 weeks after injury would still be beneficial, in the sense that your evoked potential would give you a sense.
The neurologist is perfectly happy to prognosticate up to a point by 24 hours.
Exactly.
After coma, post-anoxic encephalopathy, for example. And very simply, if you've lost 2 out of 3 brainstem reflexes, you're not going to make it.
By the way, in completion to the answer to your question, is a very recent paper, I will speak when I speak about coma, about CNEC from Australia and another co-author. speaking about 24 hours ACPs after coma, which trauma or non-trauma. And he says that these are the most useful ones. I speak about how early we can do them. So they are very valuable. First 24 hours in 6 instances that I will not go into detail now.
And the other caveat is children. They are different.
Yeah. When wouldn't it be outside the scope of a standard accepted procedure to get evoked potentials and say somebody with a Ranchos level 2 to 3 that you're seeing maybe at 4 or 5 months that they've been in the nursing home and say, gee whiz, why does, we never really had the rehabilitation doctors stop by and see him. We would like to prognosticate, maybe coma stimulate, all these questions that we're posed with on a clinical level. And when would you say it's not appropriate? I hear 3 to 4 weeks, 1 month. These are the things that we need to know and what's going to be accepted and what's appropriate and in terms of randomized prospective studies that may be pending right now.
I don't have any personal experience in dealing with a brain-injured patient, 4 or 5 months after trauma and doing evoked potential studies and evaluating the overall prognosis. But using an inference from our work in strokes, where I have done patients as late as 2 years, 6 years, and most recently 18 years after a stroke, what we have found, at least in the stroke, is that your somatosensory evoked potential pattern remains unchanged, as I said, as long as even 18 years, like in this patient, from the standpoint of what it corresponds with in terms of the clinical outcome. I mean, I didn't do the patient 18 years ago, but what I'm saying is that the clinical picture that we saw in this patient, who is a patient that had a left-sided hemiplegia, corresponds with the type of somatosensory evoked potential study that I would have expected in a patient with this kind of individual outcome. And a number of other patients that we followed were done 2, 3, 4 years and repeated from following them for that length period. And we didn't find any significant changes in their SEP even after this long period of time. But as I said, that's our experience with stroke patients, not with brain injured patients following trauma. So it's just an inference, but I don't have the data to prove it.
I think it would be interesting, though, to look at one question. Your patients with strokes were all strokes in adults. I think it might be a different story if you looked at infantile hemiplegia.
No, but all published work on the brain injury show that there is a very good correlation between the degree of the disturbance of the secondary potential of the melody and the outcome of the brain injury. And I didn't hear exactly about what you said about reflexes, that a neurologist, by studying reflexes, can say just as much. No, this is not correct. I'm sorry.
Let's look at it from the depressing point of view. If you've lost 2 out of 3 brainstem reflexes and they're still not present by 24 hours after some intracranial catastrophe, your brainstem's shot. Now, the converse, if you have brainstem reflexes and far-field type potentials, your brainstem may be okay, but your forebrain may be gone irreversibly. And so you're going to enter a chronic vegetative state. Fair enough. But I mean, if you could do evoked potentials of any kind at any 24 hours or longer and say, great, this person's going to make it and make a good recovery, but that, as I understand it, is just not the case. You can give a gloomy prognosis by their absence. You can't give them a rosy prognosis by their presence.
But there is no change of brainstem reflexes in aphasic patients, and yet in a aphasic patient many years ago, I could grade their prognosis according to the disturbance of the evoked potential. But again, the late evoked potential, not the early one. And here I want to have this notion clearly understood.
You lead into something I've long wanted to ask you, I never have. Why did you use aphasia as a criteria of cortical injury? Why not look at somatosensory function, which is much more directly related to somatosensory potentials?
I will answer this question in 1 second, but let me finish the sentence. What one has to be aware of, that if you have a 60 meter per second conduction velocity in the fast fibers, if you have 10 meters per second conduction velocity in the, not in the delta fibers, in the slow fibers, then you expect, instead of 20 millisecond arrival, you expect 20 times 6, which is 120 millisecond arrival. And this is where you have to look in order to understand what can be changed if these slow fibers are involved, okay? Now, why I did the aphasic for the simple reason, my first paper, which is completely neglected, just stated that using studying a hemiplegic, one finds a considerable difference between those patients who have normal evoked potential and those patients who have absent or abnormal evoked potential. This was the paper by Smith. The next paper, I studied aphasic for the simple reason that they are cortical involvement. Therefore, I thought that was the most appropriate for evoked potential.
Yeah, that also was before the days of neuroimaging, so you...
About coma stimulation, DiMancesco in New York can tell you that he's doing coma stimulation starting with 4 weeks and continues to 3 months or more after coma. Okay? Dr. Jeffrey Cole, finally.
Thank you. This is apropos Dr. Jewett's comments earlier and something you just mentioned about common mode rejection. To follow the old adage, I'd rather be lucky than smart. Once when I was doing some electrospinograms, I was using a double needle system in a way of getting closer, getting a nearer field potential without hopefully being within the too deep areas. I had a needle that was bad, and so I just quickly grabbed a Copeland-Davies, a surface clip electrode, to sort of bypass the more rostral needle, and found that I had terrific responses after that. Playing with several different electrode montages, I found that using a 25 or 37 millimeter monopolar needle for my active and a surface clip for my reference augmented the signal to the point that I can get electrospinograms with a single sweep. I don't have to average. Now, I'm well aware of common mode rejection as an engineering phenomenon, balancing your electrodes, balancing your amplifiers. I've never gone beyond that and looked at common mode amplification, which is the corollary to it, in terms of its responses. Have any of you ever looked at that? Purposely looking at different areas as you're looking at different geometries, looking at different electrode balances, things like that?
Excuse me, I've never even heard of or thought of the idea of an amplification in this sense. But if I understand what you've described correctly, my guess would be that it would be important to measure the fields there in the sense that as we were just discussing outside this room, but basically our mental model of a dipole in a sphere is simple, and that's its only good quality. The negative side is it doesn't match to very many brain areas, body areas, except the skull. Certainly limbs are cylinders, and in fact even the body is essentially a cylinder compared with a sphere with the head at its center. So the issue is that in a cylinder, it's likely that there is no drop-off axially, but there's a radial drop-off. So I would interpret what you just described as that essentially you had one electrode nearer the generator and nearer the center, and then your surface electrode was near the surface.
Right.
And that is the same as having an electrode in a sphere, one at the center and one at the surface. So that I was expecting that you were measuring the field that was there, and there was no artifactual event at all. But we don't know enough about cylinders and spheres and the fields within them as we should under these circumstances. But that would be my first guess as to explain the phenomena you have.
When you run your next model, look at unbalancing your electrodes and see what happens.
Oh, okay. Well, I'll work on that too.
Okay.
Busy. Yeah. You know, whenever we talk about volume conductors, we usually look at Laurent-Dunot model, which does not apply.